Right. Let me just... Right. Good morning, everyone, and welcome to our webinar this morning, which is Community in a Time of Crisis. And this is the very last webinar in our COVID Voices and Conversations series. So it's great to have so many people with us. We have, I think, 100 people registered today, so plenty of opportunity for chat, and we're going to take you through hopefully an interesting hour together. So I'm Rachel Matthews, and I'm the Programme Manager at National Voices, and I'll be co-chairing this webinar with my colleague Rebecca Steinfeld, who's our Head of Policy. And I'm supported by my colleague Sam Beatty from National Voices, who is helping us with all the technicals this morning. So before we get into any more detail about how we're going to run our conversation together and who's with us and joining that, Sam, would you just like to give us a bit of a background on the technicals and what people need to know about how things are set up this morning? And I would just like to say we're just getting used to using Zoom at National Voices, so just bear with us. It's maybe a little bit clunky, but I appreciate anybody's patience on a Friday as we work this through. So Sam, over to you.
Morning everyone. As Rachel said, I'm the comms officer at National Voices. Before we kick things off, I just wanted to say that we are recording this webinar today, and it will be available on our YouTube channel later this afternoon. As Rachel said, we've got our excuses in early. This is our first time of using Zoom. We've done 12 webinars this series, and we thought for the final one we'd just mix things up. So if you've never used Zoom before, in the bottom left hand corner is where you control your mic, but today that we're going to be muting all attendees, and we want you to contribute in the chat. The main features for you today are the video button, which is in the bottom left. There's no obligation to have your video on. If you want to have your video on, please feel free to have it on. The main feature is the chat icon, which is the speech bubble in the middle of your screen at the bottom now. If you could press that now and just introduce yourself on the chat, that'd be great. You can message everyone on the chat, or you can message people privately, and that's totally up to you, given what question you have. If you have any technical queries, please feel free to message me at any point during this webinar, or email me at sam.beatty@nationalvoices.org.uk. The other final thing is with Zoom is that you have the enter the full screen, which is the top of your screen at the moment. But we recommend that you don't do that. It's just an option. You're best keeping it out of full screen option so you can have the chat alongside while the webinar is going on. And I think that is everything. Back to you, Rachel.
Okay, lovely. Thank you very much, Sam. So because there are plenty of us on the call this morning, we want to just try and encourage people to put things into chat, and then we can give time to our guests who have very kindly given up some time to join us, and I'll introduce them in a moment. And before we get into the topic, I wanted to hand back to Rebecca for a minute, just to bring us up to date on some feedback. We have some slides, which I've just, before I take you back to Rebecca, just to give you a sense of the timing, provided some feedback on one of our previous webinars, and then we have a facilitated conversation, and then some period of time for reflection about what we're hearing and what we're picking up from the chat as well. So Rebecca, over to you, I think, with some things to share with us from a previous webinar.
Thank you, Rachel, and thanks, Sam. So hi everyone, welcome to our webinar this morning. I'm Rebecca Steinfeld, I'm the Head of Policy at National Voices. What I wanted to do is just to share with you some of the feedback that we had from a webinar that we held a few weeks ago about whether COVID-19 is widening the digital divide. And during that webinar, much like this, we hosted a very lively discussion in which we surfaced some of the positive experiences that people have had in relation to digital healthcare during the crisis, but also where there are barriers to access and use, and where people are falling through the cracks, and what the system really does need to do to both make the offering better and also make sure that it retains existing face-to-face services for people who cannot use digital services. And for that discussion, we were joined by a couple of people from NHSX, which leads on a lot of the digital strategy work for the health system. One of those was Emma Halliday, and she was sort of in the hot seat where Olivia is today, sort of listening, reflecting, and then sort of responding sort of on behalf of the system about sort of what actions she could take forward from what she'd heard. And so we followed up with her, and she has shared with us what she thought of the experience of the webinar and then what actions she's taken. So in terms of her reflections, she said that she thought that the session was really useful. She said that it was so good to hear from a variety of people and organizations. She said that it solidified in her mind the need to have more conversations with grassroots communities, and especially to co-design from the very start of any sort of policy initiative. She had offered at the end of the webinar that anyone who wanted to reach out to her for an individual one-on-one discussion could. And I think that one of the attendees did, and she said that it was a really interesting and helpful conversation. And she reiterated that if any of you want to get in touch with her, that her offer still stands. So if you want to talk about the work that they're doing at NHSX and offer opinions on that, or get more involved in projects from the get-go, please get in touch with her, emma.halliday@nhsx.nhs.uk. If you could just go to the next slide, please, Sam. So yeah, she also said what sort of concrete actions she had taken as a result of what she'd heard on our webinar. And those were as follows. She said she had provided an update on what was discussed to her immediate team. She'd reached out to health inequalities for a meeting. I think that's probably the sort of the cross health system tripartite inequalities group. She said she'd mentioned the notes that we'd shared with her, the sort of summary of the discussion, that she would write that up in her digital inclusion report for NHSX, and that she had noted the need for more conversations and co-design within her own project plan. So we wanted to share that with you to show the sort of immediate impact that we think that these webinars are having, and the way that we've structured them by sort of foregrounding people with lived experience and the charities that are supporting them, but also having system leaders in the virtual room to sort of listen and reflect and then take forward the action. So that is some good news about impact to share with you today. Back to you, Rachel.
Right. Okay, thank you very much, Rebecca, and it's really important to hear what happens as a result of these conversations and where that information goes. So we're going to move on now to the facilitated conversation, which is around our central topic today, which is community in a time of crisis. Community can mean different things to different people. Right now, during the middle of a COVID pandemic, and in recent years through traumatic events here and overseas, we have the sense of the very challenging experiences around community, and I think some hopeful insights as well that need sharing. So I'm absolutely delighted that we have some guests with us today. We have Samira Ben Omar, Kirit Mistry, and Natasha Howard, and Olivia Butterworth. So each of them are going to introduce themselves as they speak, but we wanted to get some very different perspectives around community, some local perspectives, national, and also about new communities that are forming as a result of COVID. And Olivia, who has joined us as the NHS England and NHS Improvement Head of Public Participation, is going to be listening in and joining in the conversation towards the end and sort of picking up some reflections around that. So if we could just move to the next slide, please, Sam. We just wanted to start off with a conversation, really, which is, you know, what is your experience of community? And that's when I'm going to begin to invite Samira, Kirit, and Tash to sort of think about that question. And if you have some thoughts around that, what does community, what's experience for you? You know, how is it valued? What do you get from it? Is there anything new? But can I start off and invite maybe Samira? Would you like to start and introduce yourselves and tell us what's it like right now?
Hi, Rachel. Thanks for inviting me. So my name is Samira, as Rachel said, and I'm currently working as Assistant Director for Equalities across North West London, collaboration of CCGs. And I'm also working on a program called Community Voices, which is a social movement for change in how we connect with communities to deliver change. So what is the experience of community right now? So I think there are various communities within communities, and it depends on what it is. We tend to, as organizations, tend to think that communities are out there, but actually what really COVID has showed us was actually there are individuals within the system whose communities have been affected. So there's a tension between, are they working in supporting their communities, or they're working in their day job? So we define and redefine communities in relation to whoever is in the room. That is a community, not as you being a member of staff, you being a member of a clinician, or you being a community member. It's what brings you together. What is your shared purpose? So wherever there's a shared purpose, there's a community there.
Lovely, thank you very much, Samira. And Kirit, your perspective on community right now? just check you're not on mute.
Good morning. Thank you for that. Yeah, so I'm Kirit Mistry. I'm from Leicester. So we're currently facing our second lockdown. So that's kind of been quite challenging. But from a patient point of view, I'm a diabetic patient. So I support a lot of diabetic South Asian patients here in Leicester. And some of the kind of feedback we're getting is obviously there's a lot of anxiety, because I also work for a BAME mental health charity as well, and increased anxiety, a lot of confusion around not getting the shielding messages, and some are getting it very late. And most importantly, I think there's a lack of engagement, and the messaging hasn't been culturally sensitive. So what I mean by that is we're seeing a host of translation materials coming out, but what was needed at the onset was a possible helpline with different languages that people could ring to alleviate some of their concerns and fears. So I think that's been the three main areas of confusion and challenges that we're facing here in Leicester. And now we obviously, as the city with the highest breakout of COVID, it's something that what we're seeing is a lot of panic engagement. And what I mean by that is, you know, with Leicester's diversity, we are here, but we're here, but not seen or engaged. So I think we're seeing a lot of panic engagement, and that's something that hopefully we need to learn from. Thank you.
Thanks, Kirit. And I think it's just important to note about what COVID has done in terms of the nature of relationships and how people get together. And obviously Leicester is experiencing a really difficult time. So we hear that, and obviously your own personal experience around living with chronic conditions, long-term conditions. So thank you for sharing that, Kirit. Tash, I think you bring in a different perspective around things that have emerged as a result of COVID. Would you like to just share where you're at with it?
Yeah, hi everyone. So yeah, I'm Natasha Howard. I'm here in my personal capacity today as I'm a shielder. So I've got Crohn's disease and on immunosuppressants, which means I'm having to be really careful. And I guess part of the reason that I'm here, as Rachel has shared, is actually the community of shielders coming out of this crisis has been really key. There've been a lot of pros that have come out of it, and connecting with people that you wouldn't have otherwise necessarily connected with beforehand. And I think the perspective that I'm coming from at the moment is social media. And before all of this, you know, I used social media, but I wasn't big on Twitter, and I started sort of seeing things that were riling me up a bit, and I wanted to start exploring, you know, what other shielders were experiencing and what they were thinking. So the use of social media for bringing people together, things like Twitter of all backgrounds, all conditions, it's amazing to see what's come out of that, and building that community online. And you know, in my day job I work with charity, and we do a lot of online communities and community work there, which I'm happy to talk about later. But in terms of that support network of shared experience, of sharing ideas and rallying together over something, has been really key to be able to get through this and have that network of people who, you know, in your current community, particularly as a young person, there aren't many of my friends who are also experiencing shielding, and although they're supportive, they don't quite get it all the time. So it's been really amazing to kind of get this group of people together, who are from all parts of the UK, sometimes even other places in the world, to connect with and get that support network that's really missing, and also a really good way of picking up information and sharing guidance that might have otherwise been missed. You know, things we all know, the guidance hasn't been always as clear as it's needed to be. So it's really brilliant to be able to hear, you know, from people who are listening every day and trying to understand and work it out together as well. So yeah, I've got a lot more to say, but I'll pass on to somebody else for now.
Great, thank you very much, Tash. So a couple of themes emerging there. One is about the use of social media. There's something about how we share information, and then there's something about the level of a sort of a sense of intelligence that's held out there in whatever community, how we ever define that. And I'm just wondering, coming back to you, Samira, if there's any sort of reflections from what Tash has said about social media, how people are connecting, and I'm just encouraging others to if any of this is resonating with you in the chat, or anything else you want to bring in that we want to try and pick up in the conversation. Samira, any further reflections?
So I think so when we started just looking at this phase of community voices, because community voices, the work that we've been doing has started really about 4 years ago, really looking at how we connect with communities using a kind of more honest conversation about what matters to people in their community, in their family, rather than actually through our organizational lens. And it was really interesting. The only way we've been able to, and these are kind of people that we tend to think they're hard to reach. Honestly, they're just easy to ignore. There's no such thing as hard to reach. And at the very early stages of COVID, I started getting lots of various emails. We think there's a disproportionate impact of Black, Asian, minority ethnic communities, but we can't access the information, and we can't really connect with them. And it was, well, just pick up what's your relationship with the community? Do you know them? Do you know them? Can you pick up the phone and actually kind of talk to a few people who can join you and actually then develop? So for us, these are communities who really may not actually kind of connect through social media, but they have their WhatsApp groups. They have their networks, and WhatsApp group is phenomenal. You know, the best way of getting a message, forget your comms, forget your leaflets, forget your information. Send your WhatsApp group to your existing, a WhatsApp message through your existing network, and you can see the proof. When it comes back to you 24 hours later, that's the spread. So for WhatsApp groups, those types of networks tend to work really well. In terms of social media, so it was really interesting just trying to actually kind of say to people, you know, how do we connect with you? What about online messaging? What about sending you information? We didn't really struggle with getting community activists, community members, BAME communities to join us in actually kind of using Microsoft Teams or Zoom meetings. But there's something about using getting information across. I mean, one of the key challenges that we had is that there are parallel conversations happening and parallel information happening, especially amongst BAME communities. There is a lack of trust with public sector organizations and systems. So they're much more likely to trust their next door neighbor who sends them a WhatsApp message saying, if you go to hospital, you die. Have you seen this video of people kind of not being, being just kind of in the back of a park or in the back of a hospital, and they're not really respecting the burial, all of those things. And that message got through so quickly, you wouldn't believe. No amount of information about actually going to hospital or calling if you're feeling unwell and you think you have COVID was going to do that. So I think there is something about how we connect with communities using social media, but it's not your Twitter, it's not your Instagram. People use those things for different things. Messages around healthcare was definitely around WhatsApp groups, and the power of WhatsApp messaging is phenomenal.
Lovely, thank you very much, Samira. Kirit, can I check out with you then about the experience, for example, around WhatsApp and the way people do form relationships and connect through the communities you're involved with?
Yeah, so certainly WhatsApp has been a great medium to get into communities because it's intergenerational now as well. So I know people in their 70s, 80s who are using WhatsApp because that's a new form of communication. But I think it's also important, as Samira's identified, is that I've had to do it within our mental health charity to get people on Zoom and doing things like mindfulness, meditation, breathing, yoga, different mediums to kind of connect people. And I know it's not been totally accessible, but we've enabled those who don't have Zoom or other kind of forms of online methods, their neighbors or their friends or their families have actually got it for them so they could engage, or they went into, we passed the video as a result of following the event. So I think that's been important. But what we've highlighted is people who wouldn't have used our services. We've got new people, we've had an increase in referrals, but also, most importantly, certain issues, taboo issues in our communities like domestic abuse, violence. Those are the kind of issues that we now, obviously we've been, as the charity I work for, we're a BAME mental health charity called Adhar. We've been working on those for over 30 odd years, but we're seeing a pandemic around those issues as well. And that's enabled people to reach out. So that's been kind of very useful for this. And finally, I think it's great to see that the CCG and public health are trying to engage with people through our PPGs and other mediums, but I think the resilience shown by faith communities, by volunteers, by the mutual aid groups, that has been the key to ensuring that people are supported who are vulnerable, and that messaging is further cascaded through different mediums. So that's been very good as well.
Lovely, thank you very much, Kirit. And as you're saying, there's some positive things that have fallen out of this situation in terms of being able to reach people who maybe wouldn't have been able to access services. I know there's a lot of strength of feeling and emotion. I can see picking that up in the chat. And Tash, coming back to you, I'm just wondering if there's anything that sort of you're picking up from that bit of conversation or anything you're seeing in the chat to build on some of the points you made earlier.
Yeah, I think I've seen on the chat and heard from different people as well that there are groups that aren't always being included or feeling forgotten, and whether that's the disability that's been talked about in the chat, or shielding in general, and people always feeling a bit forgotten. And that's why that thought and those ideas of community, you kind of have that sense of, well, it's not forgotten between us. At least we're here together talking about the things that are missing for us, or our needs. I think what I found quite challenging actually is, in terms of shielding, they say there's 2.2 million people shielding, but it's actually a lot bigger than that, because you've got families shielding on behalf of people, partners or whoever might be living with somebody and shielding on behalf of them, and that number is huge. And actually having one or two people or a few people trying to represent all those views of all those different people is really difficult, and you just can't do that. And I think that sort of sense of community and getting a lot of different people involved with different views has been so important, particularly with the work obviously we've done with National Voices. But it just really shows from what people are saying in the chat, but from also what I hear, that everyone's got their own experience. There are these experiences that bring people together, but actually the different views are really important. And I think that's been one of the sort of challenges on social media, the backlash that you kind of get for sharing an idea or sharing your experience. Some people might say, well, that wouldn't work for me, and sort of have that defeatist or difficult attitude, or why are you doing that, rather than sort of building on each other's ideas. So I found that actually on social media quite difficult. I'd be really interested in the WhatsApp groups, because it's sort of more private. I know it's not been mentioned yet, but actually I had to leave a Facebook group for something that I posted an idea and just shared and asked people's opinions around it, and it got quite horrible, some of the comments and things. So it is, I can really see how something like WhatsApp or something more closed like that, offline, where you're actually getting to know people, it couldn't be a better way really to form that kind of community. But where does it start? How do you hear about it? It's not in everybody's area, and that's why Twitter's worked for me, because it's just there. But it does come with those cons or those challenges as well.
Lovely, thank you, Tasha. And I'm sensing that there's a tension between the sense of solidarity that can build through these difficult times, but also everybody's experience is unique. So we can't always assume that everybody's experiencing the same thing, and there's a little bit of a tension there. I'm just wondering, coming back to Samira, I'm just wondering, as we sort of reflecting on what's happened over the last few months, what we take from this in terms of how do we continue to work together in the future? What are the things that are sort of springing to mind about where relationships may have started or strengthened? Just any reflections around that?
Yeah, so just one comment around the issue of shielding, and especially from the stories that we've heard and from the communities that we've heard. There is a real issue about how you use language and what shielding means. I can guarantee you, if you go to BAME communities in areas of huge health inequalities and you say, are you shielding? They wouldn't know what shielding means. What does that mean? And that kind of creates huge challenges. What does that mean? How can you shield if you live in overcrowded accommodation? How can you shield if you're a care worker working in a care home You know, you're and then you have people, you have family, you're living in multi-generational household. How do you do that? And I think there's a real issue around how to extend the reality versus what we assume the reality to be. And I think we need to actually have those uncomfortable conversations about what that means. The second bit, just in terms of how we move forward and how do we build relationships. If you don't already have the relationship with your community and you don't know your community already, it's exactly what Kirit said at the beginning. That becomes, you begin to have a panic engagement. Panic engagement is not engagement. It's not building a relationship. You need to have built a relationship over a decade so that you can begin to truly engage with your people. Why should they trust you? Why should they engage with you in any way? You haven't engaged with them unless you want to really just talk to them about your priorities or what you think of this service. Well, you've never really truly wanted to get to know those people in their community, in their lives. So why should they engage with you now? And just in terms of community voices, when we started, this isn't a CCG-led project. This is a social movement, an approach of how we connect to communities. So in the same way that I work in the CCGs, we have Sharon. Phenomenal. She's a community activist and community mobilizer. She has put in equally the same amount. We have Sarah State, who is a Hounslow comms person, but actually she's not working and involved in this from a comms perspective. She's working in this from her background in terms of behavioral insight and looking at how we mobilize communities. We have Mirat in research. She's working on it, not just as a researcher, but she's working on it because she understands the issue of race and the impact of race on health inequalities. So I think this is about actually, and these are the people, when you talk about hard to reach, these are the people, they're not hard to reach, they are highly engaged, highly developed. And I just think we just need to actually kind of think about how we connect with communities, not just when there's a crisis. Same thing happened with Grenfell. You know, your first emergency contact is not it's your community. When Grenfell happened, the first people who were down there helping others were, you know, along with the fire service, along with the ambulances, were the community. So we just need to actually kind of think about community in terms of what they have and what they've done themselves. And they're not waiting for us to give them permission so that they can engage with us. They decide, you know, if it suits them, fine. If not, then they won't.
Rachel, can I just come in here to sort of share sort of feedback from the chat? Because I think, you know, what Samira and Kirit and Tash is saying has really powerfully resonated with a lot of people. I think particularly, you know, the switch from language of hard to reach to easy to ignore, that's had some, you know, lots of people I think that really agree with that shift. And also I think the sort of the vital role, like literally the vital role in terms of what you were saying in terms of Grenfell, but also like thinking about for people who have nobody to support them, no family, maybe no friends, the sort of the role there of community groups to sort of step up into that space and provide people with support. Another thing that's come up is around for people, the sort of the profound understanding that can come from your peers and perhaps not from others, and the need for that in this moment, given how, you know, extreme people's experiences are. I think what, you know, a lot of people have been agreeing, not everyone can access social media, and there's a real need to go to where people are, to stick to sort of old-fashioned methods like the telephone, to really consider the needs of people with physical and learning disabilities. And I think there's also maybe some slight pushback, sort of the idea that the community is not a substitute really for sort of state action, perhaps for the welfare state, and that though it plays a vital role, we mustn't take the onus off others. And somebody has shared a really powerful example actually of sort of great cross-sector working in their primary care network. This is what Nicola Kingston said, which I'm just going to read out, that we gathered local people's views from the WhatsApp group, faith group, local people, and then reflected back to the surgeries on things they could do better. And within 2 hours, one surgery had changed the front page of their website. So that's a really powerful example, I think, of how communities can bring about change really fast, working together with statutory organisations. So that's the chat.
Lovely, thank you very much, Rebecca, and that's a great example from Nicola, and I'd love to know how we can do more of that. And just picking up from Samira's comments around the sense of how do we build relationships, maintain trust, and then we can carry on and work together. So I'm just going to go back to Kirit. Any reflections from your perspective about getting relationships in place in the first place and how we build trust?
Okay, so for a number of years I've been kind of having frustrations around not seeing the lack of diversity on various patient forums, various national structures, So that's something that I think for people who are on the call today, it's don't wait to be invited. You've got to knock on those doors where you feel there's challenges. For example, I knocked on my CCG door to say, where's your patient representation on diabetes? There wasn't, so that enabled me to engage, and then that's helped us to create better relationships. That's the first thing, so don't wait to be asked. Secondly, we've got a great opportunity now. This Black Lives Matters agenda, obviously sad to see what's happened, but it's given everyone started to talk about the historical health inequalities, race equality issues that is on everyone's agenda now. So we need to capitalize on that and take the opportunity to ensure that we have a race equality strategy, a health inequality strategy that is inclusive and engages, the wider communities. Thirdly, a coordinated approach has to be the key forward. We've had a lot of institutions setting up their, various diversity forums, patient public involvement forums. I think recently, again, thanks to the National Voice, I've engaged with their Voices for Improvement project. There's also NIHR now have set up the Centre for Engagement, so they're looking at engagement. So that's something. And through a colleague of mine who have been working with Rudy Page, who's from we're both Royal Society Arts members in fellows. We have seen, and for a number of years, the real gap is what's missing is, and we're calling it a patient public inclusion advisory group, bringing public health information and community intelligence together. That's something that we really need to be looking at and working with organizations to ensure that is the public health and intelligence is got to be the key, because our communities are better incited in terms of they know their communities better, as Samira said. They know what their challenges are, and sometimes it's not us as communities or patients that are hard to reach or easy to know. It's actually the institutions are hard to reach because they don't want to engage us. So I'm going to leave it at that, but I think it's a coordinated approach that we need to be focusing on.
Thank you very much, Kirit. And what I'm picking up is that this is an area where there's actually already has been a lot of work. And I think at National Voices, we're thinking about two things. One is where we know there is very good practice, how could we do more of that? There's something about really focusing on where it works. And there is also something I'm picking up that people feel very strongly about this, but also there is a sense of exhaustion as well. There's a sense of, we've been around some of these issues many times. So I'm just really just picking that up about, we need things to feel like, they move into a different way. They move a different way. So I'm going to come back to Tash now, and then we've got about just under 5 to 10 minutes left just to finish off this portion of the conversation. So Tash, anything picking up for you about what's been said for Kirit, Samira, or in the chat?
Yeah, this idea of the coordinated approach is really resonating with me at the moment, actually. And when Kirit was talking about the community knowing what their challenges are. So in my day job, so I work for Dementia Charity, and in their innovation team, and what it's all about is working with communities. So not just speaking to and just leaving it there, but actually working with people to understand what their challenges are, then working with them to come up with ideas for solutions, and then testing them with the communities. So it's really seeing those skills and expertise and knowledge. The communities are the experts. They know what's affecting them. They know what's needed. It's about organizations coming in and helping to facilitate that, and that's how I kind of see that coming together, that approach, and we try and do that within the work that we do, and it's something I'm really passionate about, and it's been really interesting to be coming in from the other side of that, and seeing the work with National Voices, how that's actually working, coming in from the side of the community. And I just think that's so important, that it's more than just listening to, it's working with. So I think that's something that I've really taken from this time and from this conversation as well.
Lovely, Tash. And I think both around community engagement and the way we work with patients and service users is there's often sometimes a really confused motivation and rationale underneath it. And I think we need to be much more honest about that, about why and what do we want to work on together. There's something about getting greater clarity. And I think you said it there, Tash, about it is working with people in order to solve issues or problems that make life difficult to live, or whatever it might be. And I'm just going to go back to Samira and then Kirit and just see any questions around that or responses around that about the motivation and the rationale for this.
So I think, so just for me, from my perspective, the issue about a coordinated approach to how we actually kind of work to address long-term conditions or improve patient engagement works really well in terms of how we make our PPGs, our PPI systems more inclusive. It works really well. I think if we're going to address population health outcomes, we need, and reduce health inequalities, we need a different system. Because I think those structures, for me, are set up by our own organizations to serve our organizational goals. So not to actually kind of deliver what needs to happen within our communities. Our communities actually kind of work in different ways, you know, and connect with us in different ways, and they connect in the way they want to connect. And it may not be through our existing structures, but we need to actually kind of the other way, it's a little bit turning it on its head. It's how do we become participant in how they connect within their communities? You know, to what extent have we had you know, and some trusts and some organizations have done phenomenal amount of work to actually kind of push this forward. But how many organizations, their chief execs or their chairs literally just sit, just go as participants, not because they're going to present and then actually leave, just go and as participants in sitting in community organizations, just listening in, just engaging. You know, how often does that happen? To what extent that happens? Because only when that happens, that actually kind of we begin to change the lens through which we look at how we deliver health, not how we deliver treatment, how we deliver health and how we reduce health inequalities. And so I think we need to think about an emergent model, not a model that we already know. We need to think about not going out with questions, but actually kind of thinking through what the questions are with our communities. And I do have to have a real shout out for her patience, real patience with Olivia, because she's really supported, you know, funded this approach, thinking, I'm not sure what it is, but I think there's something here about actually how we use social movement approaches, and kind of constantly and consistently funded and supported and kind of mentored around this approach. So I think there is something about how we do this and how we support each other in something that we might not have figured out completely. And I'm a control freak. I like to control things, but there is something about letting go and actually kind of just think through the approach, the methodology and the methods that we use to connect, not to engage with our communities, to truly connect with our communities.
Thank you, Samira. And we're coming to the end of this part of the conversation. Sam, I wonder if you could just move us on to the next slide, because there's another question we want to bring into play. And I want to go back to Kirit and Tash as well before we invite Olivia to come in and respond and pick up whatever there's been sort of coming out from that. So we've got another question here about, I suppose Samira's just started to sort of answer this a little bit, but is how can we best work together in this area sort of from now on? And I'm just wondering, Kirit, if you had any things that are going through your mind listening to that bit of the conversation about what sort of is the ask for you for now?
Sure. So I think Samira's alluded to is that we need to start off with a blank sheet of paper and say to our engagers, communities, patients, that what do you want to see in your area? Here's a blank sheet of paper, and let's include them as a starting point. We need to move away from this tick box mentality that has driven organizations who are in control to say, well, you know, we've got all these policies and strategies, but really they're just paper-based. They're on the shelves. They're not really embedded within the organization or in the community. Those strategies and policies need to be embedded in the community as well. And look, from what I had to do is I worked for 2 hospital trusts. I did 4 years of community engagement, particularly with patients who are transplant patients, donor families from BAME and faith communities. And after 4 years, both of these hospitals decided we need too much engagement. I had 50 ambassadors who are the right messengers. So I had to then create the South Asian Health Action Charity, which is a patient community-led charity, because I had 50 ambassadors in 2 different cities who were we're left home and dry by the two trusts to say we've done enough engagement. So what I'm saying to all of the people on the call is that if you're passionate and if you feel that there's injustice, you've got to follow that. And we are, people like us and others who are on the call, reach out to us, because we want to make sure that we don't suffer and people don't suffer in silence.
Thank you, Kurt. And there's definitely something about sustainability there, but if it's episodic and then people are picked up and put down again, so there's definitely something around sustainability. Tash, a couple of quick words before we move on to the next section. Anything you'd like to add?
Yeah, just on this whole thing of bringing communities in, and to answer the question number 2, working with partners to understand the communities. So we did some work around LGBT plus people affected by dementia, and the only way that we can reach and understand people within those communities, and I always say communities because there are many communities within one, is actually working with those organisations who are in touch with those communities to really understand how best are we going to connect with people, you know, and then actually speak to people through that. So I think that's really key, partnership, organisations, and not just thinking, you know, you can do it all, you can put something out in your comms and attract people to come and talk to you about things, but actually working locally with the right organisations, nationally, whoever might be able to put you in touch and help reach people properly.
Lovely, thank you, Tash. So could I just extend very sincere thanks to Samira, Kirit and Tash for joining us this morning and giving up their time and speaking so eloquently and with great passion about the issues that really matter to them, and also giving us some really useful clues and direction about what needs to evolve and change and what we need to pay attention to. So thank you to those 3. And if we can move to the next slide, I'm now going to invite Olivia, who is a head of public participation at NHS England and Improvement, to let's hear what have we been hearing, what have we been seeing in the chat. And Rebecca, my colleague, is going to help with that part of the conversation too, maybe bring in some other issues from the chat. So I hand over to Rebecca and Olivia. Thank you.
Thank you, Rachel. That's great. So I know Olivia's really keen to get chatting and has already warned us she might talk a bit too much. I'm just going to warn you, I'm afraid that I'm going to have to cut you off with at least 5 minutes to spare, because we really want to get some feedback from everyone. We've got some poll questions to put to you, and I want to tell you about our upcoming events. But I asked you in advance just to sort of, you know, sit back and listen and reflect on what you've heard. And we've obviously heard an awful lot about both what's working well, but also, you know, real frustration about language and framing, episodic involvement, tick box exercises, all of that kind of stuff. So it'd be really nice to hear from you now about, you know, so how you see the role and value of communities, what you think has worked well and what hasn't, and also what actions you think that the system could take to ensure better engagement, better co-production with and for communities. So over to you, Olivia.
Thanks, Rebecca. And, you know, I put it in the chat. I cannot agree more with everything that has been said. So for a bit of context, my background from many years ago, I'm too old to think about now. I'm a community development worker. I absolutely passionately believe in the power of community. And that's the advantage that we've seen through COVID. If there's, you know, positives to pull out of what has been the most horrific crisis this country has experienced, it's that the power of communities absolutely has shone through. Sadly, in some places, systems, formal organisations have ignored that and gone, we can't engage with people because it's actually, our engagement is a tick box exercise and it's a bureaucratic thing that we don't need to do right now because we're in crisis and we need to just respond. And they've cut their communities out. In other places, they've done exactly the opposite, because they have realised they cannot, absolutely cannot respond to the needs of everybody without engaging with people. And we need more of the latter rather than the former. So I'm just going to mention a few things. I'm going to start by saying I could talk about this all day. We've set up a National Engagement Practitioners Network, and I know Bren's on here and a couple of other people who are already members of that. I posted the email address to join it. It's a co-produced network. It's not ours, it's everybody's. And it's just a space to bring people who work in engagement, who are passionate about engagement and involvement or participation, whatever word you want to hang off it, into a shared conversation. So please email us, join that network. There's a nice newsletter that we do, and it's very much our network. So I think I've got a few catchphrases, and Samira's already used a few of them, but you know, I've been talking to colleagues about it's not what you do, it's the way that you do it. Because actually we've heard this in what people have said, you can do the tick box engagement, you can run a workshop and people rock up and they say what they want to say and then they go away again and then nothing changes. That's what engagement in the NHS quite frankly is. And we expect people to come to us in our spaces and use our language and understand our systems and understand how difficult it is for us. And we have to turn that on its head. That starts with the language. So please, can we just stop talking about patient and public involvement, patient and public engagement, or PPI and PPE? We just talk about people and communities, because that's who everybody is. And it is communities plural, and this point's already been made. We're not one community in a geography. Even within a community of interest, we're not one community. We're all individuals and we all have our own experiences. There's something about the respect and humility to be able to connect and listen to on people's own terms, not the terms of the system. And Samira said that very much about we've got to encourage people to get out, to sit in, to listen, to get alongside. And another one of my catchphrases is about we've got to stop doing to people and start working with people and really build those respectful, long relationships of trust and partnership that recognise the assets that people bring to this. During COVID, I've been working on the homelessness response. So I've been the NHS lead for supporting people who are homeless, and particularly in how they've been accommodated into hotels. And actually, engagement has been a critical part of that, absolutely critical part of that. I could not have done what I've done throughout this period without having regular weekly check-ins with people who are homeless. And I've done that through phone calls, through video calls. I've worked with Groundswell, who are phenomenal. The Faculty of Inclusion Health have an Experts by Experience group. They've all been so generous, absolutely generous, in telling me how it is and telling me what they need me to focus on to make change happen. And that's what we need more policymakers to do. We can't sit in a dark room and design what we think the future needs to look like to do to people. It does not work. If you're interested, I did a little podcast back in January about primary care networks. It's a pinned podcast on my Twitter. I was saying all of this then, and I'm just increasing it now. You know, we had Marmot published just before lockdown. Marmot quite clearly shames the system. We have not made any progress on addressing health inequalities for the last 10 years. That is disgusting. There's been loads of money put into it. It has not changed anything. If anything, things have got worse. And I think COVID has then highlighted that. So communities, that people who live in communities of very high deprivation, BAME communities, inclusion health groups, we knew and we have known for years that they experience disproportionate health inequalities, that quite frankly, a lot of people are living shit lives, and they're living shit lives because the system does not support them. The system expects people to put themselves into the system box and comply. And it doesn't work. That's why we don't get uptake rates of influenza vaccines. It's why people aren't accessing services when they need to access services, because they do not meet their needs. And until we start to shift this and recognise that we have to engage with people, and through engaging with people in really meaningful, co-productive ways, we will not shift health inequalities. And that's why we failed. So my joyous bit, this is proper joyous light at the end of the tunnel. I have never heard my colleagues in NHS England Improvement. I've had lectures from people recently about, oh, Olivia, so we absolutely need to engage with people in order to address health inequalities. I've never heard you say that before. Oh my goodness, you've had some sort of hallelujah moment. So I'm really trying to capitalise on this now. I've had really brilliant conversations over the last couple of months, actually, about how do we shift this. And shifting it is about investment and resource into community. It's about investment and resource into supporting people to engage themselves. So if you're somebody who does engagement, my plea to you is don't do it for people. Do not go off and engage with people unless the decision makers are in that engagement with you, unless they're sitting alongside you. Because as long as we as engagement people do the engagement and then provide an anodyne written report back to boards and all the rest of it, we sanitize things. And actually, you know, Andy Knox, who's amazing, he's a GP in Morecambe, talks very powerfully and eloquently about how as a GP, he needs to get out and sit alongside people and be with them to really hear them and understand what they are thinking and feeling, in order that he can think about how he responds to that as a clinician and as a CCG director. So there's loads of stuff I could say. There's bucket loads of stuff we have to look at around digital exclusion. But again, another conversation I've been having is, do you know what? It's much cheaper to provide somebody with somebody who's homeless with a phone with credit on it in order that they can access healthcare than it is to not. So it's a no-brainer. So let's start thinking about how do we help people and give people the tools and resources in order that they can access things and they can build their own confidence and capacity with the right support. Samira's point about people being easy to ignore, I've been saying, I love Samira, by the way. I'm in the Samira fan club. I've been talking about people who are easy to ignore for decades, because that's exactly what happens. We have boards who hear a patient's story that's totally unrelated to what's on their agenda, but they've done their tick box of we've had a patient story at our board. Let's not collude with that anymore. You know, we need to have boards who are absolutely held to account, and no decision should be made unless there is a proper engagement plan wrapped around it, and that it's got a proper consideration of how that work will improve health inequalities and address health exclusion. So, and it should be given the same level of attention as we scrutinise finance. So, you know, there's really practical things that boards can do and that everybody in the system can do. But the biggest things, you know, please listen to what Samira said about the humility with which we need to get out and sit with people and be with people about what matters to them. You know, we've got a brilliant personalised care programme, which absolutely describes all of this. You start with what matters to people, and that's exactly the same with community involvement. We have to stop dictating to communities what we think matters to them and start really listening about what matters to them. So I'm talking too much, but things I am doing, it's not what I'm going to do as a result of what I've heard, because I've not heard anything that hasn't surprised me. I've heard everything that I agree passionately with. I am absolutely committed to haranguing and badgering my senior colleagues in the organisation to make sure they take this seriously. And I think we have a real moment and a real opportunity to do that. I am going to continue banging the drum about changing the language. Please, can we just talk in the same language that we talk to our friends and our family and our neighbours and our communities in? Because as long as we professionalise the language of engagement, we will exclude people. And we, as engagement people, exclude people by the names we give groups. You know, Samira's Community Voices group, it says what it is. It's brilliant. So why do we call things PPVAGs and PVAGs? And, you know, we acronize everything, and that excludes people. So, you know, even on an email, spell it out, say what it is, and say it in plain English, accessible English. Because if we all talked and wrote in accessible ways, it meets so many more people's needs. I think the other thing I would say is about also seeing what people can do. So we have a learning disability and autism advisory group that usually has a whole day meeting once a quarter. We get everybody there the night before so that everybody's calm and relaxed for what are really intense meetings. And we ended up having to do one of those virtually, so we used Teams. I was so anxious about it, but actually we worked with every individual about how they were going to access it in advance. So we did sort of buddying up and training and sort of just test and social things to get people comfortable with it. When we delivered the meeting, we had the best conversation that we've ever had. Actually, for my colleagues there who are autistic, they found it easier to engage because they could control the amount of information that was coming into them. And that's really interesting. So I think there's something about really recognising what people can do with the right support.
Olivia,
and we need to do that. We need to do that with colleagues as well. So my last point is we also have to be patient with colleagues. So if I think about, you know, people in general practice, quite frankly, they have been scarred over the years from really awful patient participation groups. You know, groups of people who come in and do pointy finger and shout at them. And if you talk to people in practices, they just put their head in their hands and go, I really hate it. We have to work with our colleagues about what good engagement is and build their confidence to be able to sit in those conversations, build their confidence to not have all the answers, because that's another scary thing. You know, medical training trains you to have the answers for patients. And we need to help people have the confidence that it's okay to not know. It's okay to be curious. It's okay to set out not knowing where you're going to go. And we have to reflect that in our funding arrangements as well. I'll shut up.
Oh, I'm really sad to cut you off here, because I have loved listening to you. I think everyone here has loved listening to what you've been saying. You know, it's so refreshing, and thank you to hear someone within the system talk so honestly and acknowledge, you know, where the system has failed, where it's continuing to fail, where it's making unreasonable demands of people, and the sort of really horrendous impact of, you know, not engaging people in a sustainable and meaningful way. So, you know, thank you for that honesty. Thank you for your commitment to making this work happen, you know, in everything you've done today, and in, you know, as you say, continuing to harangue people, continuing to bang the drum. I think it would be helpful for us to know, you know, not to be answered now necessarily, but, you know, if you could maybe share it with us afterwards, if there's anything we can do to help you, because, you know, we don't want you to be a lone voice here. We want to help you to help us effectively. You know, so if there's any sort of anything we can provide, case studies, for example, there have been some great examples shared on the chat, but, you know, maybe we could help you by sort of showing the value further of what, you know, why engaging with community is so important. So we can share that, or you can share that with your colleagues, and sort of show them what can be done, build their confidence, you know, understanding that of course they are, like everyone else, dealing with the collective trauma of COVID, and, you know, are also exhausted and have, you know, no doubt witnessed horrific things. So thank you, Olivia. We are going to move on now to...
Actually, Rebecca, can I just mention one last thing? Watch out, National Voices Charlotte's been on this task and finish group. There has been a short task and finish group around health inequalities. We're expecting that the output from that will go out next week as part of a letter to the system about what to do between now and the end of March. It's really good. It's really good. It's really powerful. So, you know, watch out for that when it comes. And I think that gives us a platform to have these different conversations.
Yeah, I think it does. And you know, one of the things that will be in that, as I understand it, is the need actually on the system to proactively engage with people and with patients. And we've really banged the drum on that front. So Sam, if you could just please move forward a slide. So I can just, what I essentially want to do here is just quickly summarize what we have done in these webinars that we launched back in March as lockdown got underway, and then tell you a bit about what's coming up, and then ask you for your feedback about what you would like in terms of the format for engagement moving forward. So in terms of what we've done, so we've had 13 webinars. This is the lucky 13th over 5 months, with 600 individuals who've registered from over 400 organizations. We have covered a range of topics. I know quite a few of you have been with us on this journey and attended previous ones. We've looked at the disproportionate impact of COVID as a virus, in terms of lockdown, in terms of the recession, on BAME people and communities. We've looked at lifting lockdown from the perspective of those that are clinically vulnerable. We've talked about whether COVID is widening the digital divide, which again has come up today. It's come up in virtually every single webinar that we've done, this issue of digital exclusion. And we are really hot on that at National Voices at the moment, engaging all over the place on that issue. We talked about the unequal impact on mental health of what's gone on. I think beyond just what we've sort of covered, I think to think about what we've achieved through these webinars, I'd like to think that we've shifted the power dynamic somewhat. We actually started off these webinars sort of in the sort of maybe the bad way we've been talking about. We gave the floor first to people from the system to explain what their programs were and essentially asked people to respond to that and to kind of fit themselves into what the system was saying and sort of in a maybe more of a tick boxy tokenistic way. And then we just turned that on its head. We just flipped the power. We were like, no, we're national voices. We're going to foreground people with lived experiences and the communities that represent them. And that's what we've done in the webinars for more than, I think, 2 months now. And that's what we've done today. And I think in doing so, we've strengthened the connections between people and built community. But I think we've really supported system leaders to understand things with that blank page, you know, as people are telling it in their own words, in their own language, in ways that resonate with them, rather than the jargon of the system. And I'd like to think that in the way that we've done this, in having system leaders listen and then respond, and then we followed up with them and asked them what they've actually done, that we've held them to account in some way as well. So that's what we've done from March to today. You could go forward, Sam. What we've got coming up. So next week, we've got a webinar that we'll be sharing, if you could go back, yeah, about people's experiences of digital healthcare, rapid insight research that we've done together with Healthwatch England and Traverse about the sort of the good, the bad and the ugly of this sudden switch to offering digital GP appointments and things like that. So I think that's next Friday, the 24th of July. Then in the autumn, we're going to have a number of sort of events around projects that we've had ongoing and that we've switched all of them somewhat to focus on the impact of COVID. So we're going to have something on social prescribing, a set of statements that we've been developing with people who've been shielding about the urgent needs of people using health and social care right now in this context of ongoing COVID in the community, but also the restart of core NHS services. So we're developing these statements that we've co-produced with people in focus groups, and we're going to be launching those. We're going to be launching a project about people's experiences of waiting as a result of service delays and cancellations, which obviously is even more pressing now, given the enormous backlog there's going to be for people with physical ill health waiting for care. We've got a project about the emotional support needs of people with physical conditions. And finally, hopefully in December, we're going to be hosting a conference on health inequalities, a whole virtual conference funded by the Health Foundation, and we'll be looking at a whole range of different issues, not the least of which, as Olivia mentioned, is the sort of the collective shame that Marmot 10 years on reveals about our failures to address health inequalities and what we can do better in the future. So that's the content that we're planning. We're going to launch a poll now because we'd like to know what you've thought about the format of the webinars we've had and what you've gotten out of them. Maybe that you've only been to this one, but hopefully you've been to some others as well. We really want to know, you know, what's the most useful thing you've got out of it, and select as many as apply. You know, is it building connections in a network? Is it building your knowledge of the issue? Is it hearing from system leaders about their work and plans, or is it something else? And then we'd also like to know, in terms of future webinars, what would you like? Do you want to hear more from the voluntary sector health and care organisations, more from people with lived experience? Do you want more themed content where we focus on a particular topic? Or would you prefer it's more sort of open-ended, blank slate, you come in on that day, in that moment, you're in the room, you're the community, you tell us what you think? And would you like sort of more free-flowing discussion or more kind of structured? So please just take a few minutes and just tell us what you think. It would be great to know. That's really interesting. So far, what people have got out of it is sort of split between building your knowledge and hearing from system leaders. Oh, but you're all really split on what you want in the future. So yeah, I think that's really it from us. I think the final slide was just a thank you slide. We don't need to move to that. Let's just keep the poll open for a few minutes. Thank you so much to all of you for joining us for this webinar, for others in the series, for all of your contributions, for talking so openly, so honestly about what you've been experiencing and what you're trying to do with, you know, a relative group of strangers. We really appreciate everything you brought to this, and we're doing our best to take it forward and to have impact and influencing as well. And have a lovely summer, as much as one can in bizarre circumstances. Bye, everyone.